Welcome to Mad Medicine with Miss P. And today we're going to complete the assessment. So last week we left off on range of motion, kind of grips and pedals. So we're sort of at the groin area, let's say. We're going to defer most of that depending on your patient if they're awake, alert, and oriented. Otherwise, if they're not, you need to really inspect. I know it's no fun. I know you don't want to, but you need to really get in there. Lift, separate, get some gloves on, and don't be shy to get in there. A lot of these men have excoriation on their scrotal area, particularly near the anus and that sort of thing. And these women, they are so red and raw in their labial area. You just have to get in there and really assess that and make sure that you can fix it before it gets rough. So, and a lot of these patients that don't feel it or don't notice it or complain of burning, and we're kind of like, yeah, we give them the bedpan to clean them up. You can't do that. You need to get in there and really see what's going on and make sure that you keep it as clean and dry as possible. Even your abdominal folds, any skin that touches skin that stays warm and moist, you're asking for trouble. So you're going to get that yeasty, red, raw, and it can get bad. I mean, it can get bad to where they need dressing. So let's stop before it gets there. So get in there and really look around, and don't be afraid to do a really thorough assessment. Like I always say, if you don't go over them with a fine tooth comb, especially on admission, and maybe LPNs aren't doing admissions most of where y'all are working, but it's so important that upon admission, if you don't find a problem that they came in with, the facility has to eat any payment that goes out for that care. So if they have this rip-roaring dressing or wound anywhere on their body, and the admission nurse didn't see it, didn't catch it, didn't pay attention to it, then all of the care, the doctors assessing it, writing orders, the nurses doing the dressing changes, the techs cleaning that site up in between, and all of the supplies we use, we can't bill for any of that. So you need to look over these patients very carefully. And a lot of you students find stuff that you can't believe you can find. I had a student not too long ago come to me and say that she found a dressing on a patient's back that was dated like September 9th or 3rd or something. And this was February. Yeah, really, really not okay. So I may have mentioned that before. It still sticks with me. And I kind of thought like, surely she's mistaken. She couldn't possibly have found that. She did. And I went and looked. I said, okay, I put my stuff down, stopped grading papers, hopped up, went and took a peek. And sure enough, I'm the one that took it off. It said, like, I want to say September 3rd or something like that. So really not okay. So we need to look over these patients very carefully through their hair, any of those, folds, anything that under their arms and their groins, you have to really look. So after you get to that point, then usually I think, God, if I remember correctly, it's been a while, you kind of go over the skin. Now, usually what you want to say is that the skin is warm and dry. That's what we're looking for. We don't want it cool to the touch. And don't be judging the arms that are outside of the covers and it's cool in the room. Everybody's arm is freezing outside of the covers when they're lying in bed, that sort of thing. You want to look at the skin that's their normal temperature, generally under the covers or under their clothing, that sort of thing. So if one arm is cool to the touch and the rest of the body is normal, you're going to go with that normal side and say that it's warm and dry. Because if they're cold, one of two things is happening. That arm is outside of the covers, or your patient has deceased and nobody noticed. So we are 98.6 at our core temperature for the most part. That's pretty freaking warm. Imagine if it was 98.6 outside right now. That'd be pretty darn warm, right? So think of that as the normal temperature for a live being, and know that they need to be warm and dry. Nobody should be moist. Now, if you caught me in the middle of last night, after what I believe is some premenopausal night sweats or tuberculosis, I don't know, one of the two, you may think differently. But for the most part, we should be dry. So if they are moist to touch, and I don't just mean like these areas in here, but I mean, if you go to touch their skin and they are moist, something else is going on. If they're lying there diaphoretic in bed, either it is way too hot in the room, which could be, we've all experienced that, or they have something more going on. So your skin should be warm and dry. Anytime we talk about assessment, like we said before, there's two words that we usually use to assess or describe that site, right? So when we talk about the heart, we want that rhythm to be regular, with a reasonable rate. So we usually say like, S1, S2 audible with regular rate rhythm. While there's no such thing as a regular rate, we still want that rate to be between 60 and 100. And that's kind of what we mean by a regular rate. When we talk about our breath sounds or our respirations, they should be even and unlabored. Their abdomen should be soft and non-distended. So one word is always a little bit more important than the other, right? So when we talk about the respirations, we want them to be even more than unlabored. You can have a little labored respirations, but as long as both lungs are rising and falling, then we have less of a problem. Just like the heart, we want that rhythm to be regular more than the rate. You can be 101 lying in bed and just fine. You can be 47 lying in bed and just fine. But within a regular rhythm, we have bigger issues. So when we talk about the skin, warm and dry are our two concerns, right? And one's a little bit more important than the other one. In this case, I would probably think dry. We should never be lying there moist. Even if they're a little cool to the touch and they have, poor peripheral circulation, that sort of thing, they might be just a little cool to the touch. But if you went to deep core, one under the bed, slid your hand underneath their back to the bed, you'd get something warm. But they should never be moist. Now, when we talk about the skin color, be real careful here. I feel very strongly about this. I know there's nurses out there, there's instructors out there that always want to talk about that the skin tone or their color is normal for ethnicity. I don't know what that means. I'll never know what that means. My father was French, and which would make me of French descent. I am pasty white in my pasty white areas that never see the sun. And he looked like he could have been Mexican. Everybody always thought he spoke Spanish because he was that dark. I don't know how that changes his ethnicity. Should we assume that he's from Puerto Rico? So I don't think that judging someone's skin color, determining their ethnicity or what continent they're from, that doesn't mean it. And first of all, it doesn't mean anything. It doesn't change how you care for them. It doesn't change how you would treat them. And I don't know how looking at their skin color can tell you their ethnicity. You have no idea where I was born and raised. So, and no, I'm not from New York. But it doesn't matter in the sense of caring for this person. So if you want to put that in there, you better hope it doesn't go to court, because I don't know what you're going to decide on their ethnicity by just looking at their skin color. Guess what? Elon Musk, pretty pasty, right? Yeah, he's South African. So I don't know if you know what his ethnicity is. So yeah, Charlize Theron, yeah, she's South African, pasty as they come. So I don't know what to tell you about that ethnicity. I'd be real careful there. I don't even care about the ethnicity. I don't care what color your skin color is. Never have, never will. Doesn't determine how I assess you or what we're looking for there. Now, red, I don't care if you are as dark as that gorgeous man from Zimbabwe I met last year, or if you are as pasty as the Netherlands girl I work with. It doesn't matter. No matter what we're looking for is redness. And no matter how dark you are, no matter how light you are, that red is red. If ever you've seen someone of very dark skin color get ready to pass out, they lose their color, they turn a shade of green, and you can tell they're going down. And it doesn't matter how dark or how light they are. And those pasty white people, when they lose their color, you're like, oh, look, it's iridescent. I can see her liver. It's that significant. And if you haven't seen it, just wait, you will. But if they're red, that is a problem. That means that blood is coming to the surface. Everyone has red blood. That means blood's coming to the surface and there's a problem. So any erythema you see, any discoloration, blanchable or non-blanchable, we're going to chart and then describe it as such. So any abnormalities, you want to make sure you're charting to where you are explaining to the reader exactly what you're finding and that it is in fact a problem or it's not. So we all have pink undertones and that sort of crap. I don't know who charts that or who doesn't, don't care. But if there's any redness, first of all, you're going to push on it. Is it blanchable or is it non-blanchable? And then that's how you determine whether there's an issue, and you chart it and then treat it accordingly if need be, follow with another note, notify somebody, do something about it. But when we're talking about the skin, that's what we're looking for. We don't chart scars. We don't chart moles. We don't chart anything like that. Otherwise you'd be there, forever. So more than anything, you're looking for any abnormalities. When it's really flaky and dry, and that's like after you've tried to clean it up, then you might want to chart that. Now, what I do find a lot is those feet are really ignored. Their groin and their feet are really ignored. You kind of scrub the arms and legs, the front and the back, and then the feet and the crotch are ignored. And sometimes, the little crusties around the eyes and stuff, get in there. Don't be shy. Get in there with that soft washcloth, use some warm water and scrub. When I get my students, when I go into a patient's room and I see their feet, looks like they haven't been washed in I don't know how long, even if the techs are good, they're doing their job. I'm not even necessarily saying they're not, but the amount of time you have to spend on those feet to really get that peely skin off. Like you could literally peel it off in sheets. I've done it. Like I literally, it's a pet peeve of mine. I can't help it. You know, I have thousands. I got to go in there and pick it off. And I can remember on probably 3 or 4 different occasions, I can even remember certain people's names. Remember Ben when you went in there and soaked oh, and Josh, you guys went in there and soaked that guy's feet, and oh my gosh, I mean, like they look brand new. I mean, they looked like he had a pedicure with the fish that sucked the dead skin off and everything. It looked beautiful. And Kay, remember, Kayla, you went in there and scrubbed his feet and how much better they looked, and all that skin just came off. That stimulation alone will improve their perfusion. Why? How do you think that skin was dead and stuck on there to begin with? They're not getting any good perfusion, not getting that movement, they're not getting stimulation, not getting that exfoliation. Get in there and do that if you want to give a good bath and really stimulate that circulation to their toes, to their feet. It matters, and it will really help them. A lot of them have wounds on their feet. How are you going to heal those wounds? You can put anything you want on the outside, you heal from the inside. Your body has to heal itself. So you can do things to help keep moisture in and decrease infection, that sort of thing. But the only thing that's going to heal you is you. So we need to improve. Is that a bug? There's a freaking bug in here. The only thing that's going to improve circulation is getting that movement going and that vasodilation from stimulation. So get in there, get even kind of a rough, one of those rough washcloths, which we all have. Just heat it up, get it nice and warm to where it's not too hot, and scrub like you mean it without hurting them, and you'll see a big difference. So, and while you're doing that, assess those feet. Look in between the toes, look at those toenails. When they have that thick, curled over, calloused, scary toenail that you have to take a jigsaw to get it cleaned up, a file isn't going to do it. And even like your normal toenail clippers don't open wide enough to get that toenail in there. If that ever happens to me, I'm telling y'all, just intervene. Okay, work with me. You need to chart that. You need to say that the toenails are thick and yellow, or make a note that you need to notify the MP or whoever's in there, if it's a skilled facility, and get those cleaned up. And what does that indicate? Why would we chart that? What's the point in saying that? Do they have really good peripheral perfusion with toenails that look like that? That's not what my toenails look like. And if they ever did, I would do something immediately. So that's poor perfusion, and that is an indication of it, and that's why we chart those things. So when we talk about the skin, anything that's on the skin that's abnormal, especially this is where we talk about our IVs. So when you're describing an IV, it's always the site and the dressing. So let's say it's just a Hep lock. Or a saline lock, SL, right? You can say capital S, capital L, saline lock 2, and then be specific. This is your anterior arm, this is your medial arm, this is your lateral, and this is your posterior. So get an anatomical position and just kind of think exactly where it is and then describe it. If it's in the hand, you can say the hand. We're not putting any palm IVs in. I haven't seen one yet. Maybe one day I will. But they're always in the back of the hand, so you don't have to say the dorsum of the hand or posterior hand. You can say the hand. We know where they are. When we talk about the wrist, be specific, and then on up, especially if we're talking about a PICC line, right? How many lumens? When is the dressing due to be changed? And then you're always going to describe the insertion site. So it might say something like 20 gauge saline lock to left anterior distal forearm, depending where it is, or mid forearm, be specific. The dressing is clean, dry, and intact, and the insertion site is without redness and edema. Those are the only 2 things I care about. You can talk about there's no pain or warmth at the site or that sort of thing, but you're still indicating those same things. The 2 things I'm worried about is infiltration, edema, or hematoma. Still an infiltration, but kind of the opposite way. You're bleeding into your tissues versus fluid getting into your tissues. Still something we don't want there. And redness, which indicates infection, right? It'd be very unlikely you would have a superficial infection on your skin and not be red. So make sure that you chart those 2 things when we're talking about an IV. And then often I'll chart when it's due to be changed, especially if it's a PICC line. If it's a central line, you're going to talk about that insertion site. If it's a triple lumen, double lumen, single lumen, whether it's a PICC line, or if they've got any ports or permacats, anything like that, same thing. A lot of those dressings are not occlusive, so, or, they're not biocclusive. You can't see through them. They're occlusive in the sense that you can't see through them. There's gauze or something like that. They don't just have a tegaderm over them. So if so, describe that dressing also. And then when it's due to be changed, make sure as it's being changed, it's being clearly and carefully assessed because of the nature of where, those catheters lead to. So Now, if something is dripping, then you're going to describe that medication or that fluid that's dripping. When it's lactated ringers or saline or, 33% or a quarter percent or whatever you're, 33% or half percent, 45%, whatever you're talking about, then you're going to talk about how fast it's dripping. So I might say LR to left anterior mid forearm with dressing clean, dry, and intact. Side without redness and edema. And then I'll mention the LR is at, 25 milliliters an hour, 40 milliliters an hour, 125 milliliters an hour, whatever it is. When it's a medication, then you have to talk about milligrams, micrograms, or units. So when we talk about heparin, and I know y'all do this, I know all you nurses out there do this, and it drives me insane. Then you'll say heparin at like 6 milliliters an hour. That's not a dose. I'm assuming it's 100 units per milliliter, but it's probably best not to assume with an anticoagulant. I would probably write it in there. Or the students come back and they're like, well, the nurse said that the Cardizem is at, 10 milliliters an hour or whatever. I'm like, how much is 10 milliliters of Cardizem? I've never given a dose of that. I've never had a doctor say, hey, give him 10 milliliters of Cardizem. That's not a dose. You need to know what the dose is, how many milligrams, micrograms, or units are dripping into your patient. And then you need to know what that means. You need to understand the concentration and then, of course, what that medication means. And we'll get into that later. I promise. We're going to get deep. Put your boots on because we're going in with medications, I assure you. We're going to hit some I think next after we finish assessment today, we're going to get into probably some skill charting, and then we'll go into disease processes, and then we'll get into medications last. So, stick with me. It's going to be a long go. So that's the skin. And then don't forget about your turgor. And you don't necessarily have to say skin turgor. You can say skin warm and dry, turgor resilient, or turgor non-tenting, or, turgor poor, whatever you want to describe it. Just make sure you're recognizing that you are assessing their hydration of their tissues when we talk about turgor. A lot of you don't understand that because you want to chart that their turgor is just fine, and then you're going to give me this dehydration care plan. Oh, and we're going to do care plans too. We're going to do NANDAs and care plans. We're going to make it real easy. I promise it's not as difficult as it seems. I assure you it's not as difficult as it seems. You guys like to make it a lot harder than it is. This is the problem. This is why he has it. This is how I can prove he has it. This is how we're going to fix it. Bam, that's a care plan. I promise that's it. And we'll get into it. So when we're talking about the skin, it's warm and dry, any abnormalities you've got, this is where we talk about wounds and dressings, that sort of thing. You can go head to toe with your dressings, or you can save it for skin. It depends on what your instructor likes or what you like when you get out there, however you think it's best to be described on paper or in the computer, as a practicing nurse, and you'll kind of get in your own little routine and find what's best for you. And that's fine by me. It's not my way or the highway. If it makes sense and it flows and, I don't backtrack and say, well, why are you talking about this when it's down here? I don't care. So I never have. So basically that's the skin. Any abnormalities you want to talk about. So now we're going to talk about your pedal pulses. So I know a lot of instructors out there want you to do your radial pulses and your 50 different popliteal and that sort of thing. I will do popliteal when they are a below the knee amputation. We will do a femoral when they're above the knee amputation, right? Because you always want the most distal pulse. So if they've got both feet, you need some pedal pulses. I don't really care about your radial pulses. If you go as distal as you get, there should be good radial pulses, unless you notice there's a problem with perfusion to that arm. If they have some sort of arterial clot or occlusion or something like that, there shouldn't be any issues. And they should always be the same on each. If ever you guys are getting, I know you want to chart like a different heart rate versus that radial pulse. Where do you think that radial pulse is coming from? It's coming from the heart. So they should be the same number, and they should be happening about the same time versus the distance it takes to get to there. Otherwise, if you have any change in your radial pulses, well, then that means that there's an arterial problem, because that's what's bringing the blood there, that artery from the heart, right? And that's how it gets to be that pounding pulse you feel. It's from that left ventricle sending that blood there. So when we talk about the feet, or we talk about pulses in general, you need to grade them, right? So +1 is weak and thready. That's, it's hard to find when you finally do. It's difficult to keep. And, if you push a little too hard, you can occlude it real easily. And generally there's something else going on there. And +2 is palpable, but easily occluded. Again, not something we're looking for. I'm already concerned, right? So they should all be about +3. And if not, you need to say so. If they're not +3, which is normal, it's easily palpated and not easily occluded, versus +5, which is bounding, right? So If you were to get something, anything under +3, then you need to describe that perfusion, right? There's 5 ways to describe perfusion after we discuss pulse, because there's nothing better than the pulse, right? To determine whether we have perfusion. You got a pulse, you got perfusion. Doesn't mean it's getting completely distal. There still could be capillary issues, but at that capillary level, we're talking about refill, right? Capillary refill. Temperature, are those toes warm to touch? Color, sensory, motor. That lets you know you're getting that distal circulation. So anything under a +2, +3, if it's +2 or less, then you need to describe. You need to say it's +2, but don't panic, this is why. And then you describe those distal toes, that the color, the cap refill, the sensation, the motor, and all of that's there. If not, you may have found a problem that needs to be addressed. So get to the bottom of it and make sure that you don't let anything go mistreated or untreated. So if you find an abnormality, let somebody know and stay on top of things. I think that's about it. I'm sure I'm forgetting something, but let me know in the comments and I'll address it next. But for the most part, that's it. I feel like I've probably repeated some of that in the past, so I don't want to get too into it. So that's about it. And then next week, we're going to go into maybe how to chart some abnormalities like chest tubes and rectal tubes, Foley catheters. We can do some of those. If you've got any questions, and feel free to ask, and I'll look through the comments and I'll add that into the next video if I can. Meanwhile, we'll end it with my last, my pet peeve of the day, not my last one. Let's be realistic. But one of my pet peeves, lay and lie. It's not that hard. You lie down because you're capable of doing so. The dog lies down. Go lie down, right? That's what we tell our dog. The cat lies down. You lay an inanimate object. Let's all be mature about this. You lay down an inanimate object such as your clothes. You lay out your clothes for your husband, otherwise he'll dress like an idiot, right? You lay down something on the bed, right? I'm going to, lay my purse at the foot of the bed, or I'm going to lay something down that can't do it itself. You lie down, an inanimate object is laid down. It's not that tricky. Okay, so I think that's it. If you've got any requests or anything like that, let me know. I'll see if I can't add into these next videos. Other than that, hugs and kisses. Love y'all.